Okay, welcome everybody. We will start today our pharmacology lecture. We will talk about the central nervous system depressants, muscle relaxants, and anti-epileptic drugs. Okay, so let's start talking about a few things about sleep disorders, but we need to know what is sleep first. So it's a state, some books that say unconscious or semi-conscious, from which the person can be aroused from appropriate stimulus needed to maintain psychiatric equilibrium. What is important about this is, I'm not going to say the whole story again, but with the time we sleep less, I mean with the decades in the 60s, 70s. And what is the problem about this? The problem is that some studies are saying that sleep less than 5 hours increase your risk 3 times for myocardial infarction. Okay, so that is something that we need to keep in consideration. So sleep is one of the main activities in our life. We sleep about 1/3 of our life. All right, so here we have some questions for NCLEX that I want just to be sure that we are getting there. So what is a normal sleep? Normal sleep phases. So we have two phases, the REM and the non-REM. REM and non-REM. I should put first to non-REM because it's the first stage. So stage one, you start with no REM, all the red here. Stage one, stage two, three, and four, and then we have the REM. The REM is where we have the deepest relaxation of our muscles. And just to go straight to the point, we have, for example, medications we use to induce sleep, what we call hypnotics, that they are going to decrease the time of REM. So it's going to be less than 25%. Okay, so one more thing that in NCLEX they ask you is about what is the longest stage. First of all, is no REM. Second is the stage 2. We have a stage 3 and a stage 4, and this stage, when we get older, we sleep less and less, right? And what is the stage who diminish is going to be stage 4. This is the stage where you're going to start having some problems, disorders of the sleep. For example, somnolence. So you're going to start walking at night. You start to have actually some, especially activity, muscular activity, stage 4. Like you can walk, you can stand up, even at the same next day you cannot remember anything. Okay, so that is about these two slides. So here we have that if you see here the REM, and this is the no REM, you start with stage 1, stage 2, 3, 4. So stage 1 start to have no REM, they go very deep sleep, go superficial, deep sleep, superficial, deep sleep, more superficial, superficial, until you get awake. So what here in every cycle is going to last this from here to here to here is 90 minutes, 90 minutes, 90 minutes, 90 minutes. The REM, that is what actually we want to have for more time, is about 5 minutes increased to 10 minutes, 50 minutes, even about 1 hour. So if you cut your sleep, for example, in this point, you're not going to continue with 1 hour sleep. You're going to continue REM sleep about 5 minutes. So you restart all over. At the end, what happened is that if you wake up many times during the day, you're going to just have a very little of REM during the whole night. So your muscles are not totally relaxed, so that's why you wake up tired. All right, so let's keep going. So we have the neurotransmitters that are going to be used for sleep, the serotonin, SAND, acetylcholine, the norepinephrine, and the dopamine. All right, so I'm not going to make too much incidence of this. Probably we can do another video about each of them. So let's keep going with what we need to treat, or what is about pharmacology specifically. Number one, we have insomnia. What is insomnia? You already know, inability to sleep. It's not a disease. 90%, 95% of the people suffer once in their life, this at least once. And this is a not normal occurrence. It's actually in healthy life, right? Okay. So insomnia can lead into other problems. Insomnia can be started, for example, over stress or anxiety. So insomnia could be part of that process. Insomnia is going to be diagnosed when you have at least 4 weeks, 4 weeks, 1 or 2 days every week of lack of sleep. That we call, that is the diagnosis of insomnia. Sometimes when you have insomnia, you go over the counter or OTC, and you will find some antihistaminics that they have, the Unison, whatever, all these brands that you have there in OTC, so you can take it. The problem with this is, and we will see that soon, that they can produce tolerance. So that means if you take it for a long time, it's not going to work, because at the end you're going to be more restless. So we are going to see that in a few. All right, so here we have insomnia and common causes. We are stress in general. That's why we summarize as stress. A lot of work. We have definitely some foods that can be caffeine, for example, large meals before bedtime, and those are nursing considerations that you need to investigate on the patient in order to make patient education. Insomnia types, so initial, so you cannot start sleeping. Terminal, that means you was sleeping and then you wake up and you cannot go back to sleep again. And intermittent is that you sleep, you wake up and sleep, wake up and sleep. So those are three types of insomnia that are going to be treated for some medications we are going to see now. So we have sedative and hypnotic agents. Sedative and hypnotic. So what is the difference? The difference is sedative calm you down. It's going to calm you down. And this is going to increase the relaxation of the person. So that can induce later on into sleep. But sedative means that is just calm you down and relaxation. Doesn't make you sleep. Sedative. In the other side, we have hypnotics. Hypnotics are going to make you sleep. For example, we have, let's put it this way, diazepam is a benzodiazepine. This benzodiazepine can be sedative, but in higher doses can be hypnotic. For example, if you give 2.5 or 5 milligrams of diazepam PO, that is going to work as a sedative. And what is going to help you? That is going to help. It's not an anxiolytic exactly, but they are going to just decrease the anxiety of the patient. Sedative, calm you down, calm you down. You know, the anxiety can, the only way to resolve is to resolve the problem, right? To recognize what is the problem that is making you worry, have fears, right? That is anxiety, and solve the problem. That is actually, it's not just medication. Hypnotic is going to make you induce to sleep. So we was talking about diazepam, 2.55 milligrams is going to be sedative. If you give 10 milligrams, for example, of diazepam, that is a benzos, can lead into hypnosis, so hypnotic. So they are going to make you sleep. All right, so that is the difference between sedative and hypnotic. So we are going to use all these medications as temporary treatment of insomnia. It's not for long time. So then we need the REM. REM is like gold for us, for our sleep. REM sleep restores mental and physiological balance. Okay. All right. So we have, these are actually some nursing considerations. So you need to have a soft light. You don't want to turn the light very intense at night, because your body thinks that it's already morning. So the hormones are going to start changing, and you start to be awake. So just prevent all these factors. All right, so then we have another nursing consideration. Are going to be very fast here. Quiet environment. Quiet environment. So quiet environment mean, in addition to that, is darkness around in your room. You don't want to have the curtains. Without curtains, that the light of the street is coming inside, so that can make you more difficult to sleep. TV in front of you, so no TV in the bedrooms, and even reading is going to be not beneficial in order to induce to sleep. So the bedroom should be for sleep. All right, so here we have the this for medication for insomnia. This is another NCLEX question. Older adults may react paradoxically. So that means that if you take sleeping pills, they are going to have some excitement, confusion, restlessness, and euphoria. So it's totally the opposite that so you want to sedate the patient, to calm the patient, is going to make totally the opposite. So that means that is mostly can happen in elderly people. Um, Now, how do you, for example, if the patient is too sensitive, there's patients who said, oh, I cannot take this pill because make me really drowsy. Yes, it's true. Some people are more sensitive than others. So if the patient is more sensitive than others, so probably small doses are going to be required to, smaller doses are need to be required in order to have the similar effect. So to recognize this, if the patient is going to be difficult to wake up. So we need to just remember that. All right, so please, sleep apnea. So you need to investigate about the sleep apnea. So as the patient is waking up, feeling that is having lack of air. So that is mostly telling you that patient is having sleep apnea. All right, so barbiturates, benzodiazepines, no barbiturate, no benzodiazepines. So we have the barbiturates and the benzos. As we mentioned before, the benzodiazepines, benzo is like Mercedes-Benz, is going to be very fast. Okay, benzo. So what is benzodiazepines? Are going to have very fast acting, and they are going to just have short duration. In the other side, we have the barbiturates. Barbiturates are going to be long-acting. So just remember, like a bar, you are in jail behind bars, so you are taking more time in jail. So barbiturate is going to last longer. They have more side effects than the benzodiazepines. So for insomnia, what you're going to use first, barbiturates or benzodiazepines are going to be benzodiazepines. All right, so at the end we have another group that are classified as no barbi, no benzos. So we are going to see that now. All right, so other treatment for insomnia. We have the antihistaminics. You take one antihistaminic, it's anti-H1, but they are going to have some sedative effects. So sedative effects, not hypnotic, sedative effects, and are used for short periods of time. What is the problem with this? If you go OTC and they say, oh, this is good for me, but as you start taking every day, that is going to lead into tolerance. This tolerance happen in a couple days or 3 days. And what is going to happen at the end, the medication is not making effect. In addition to that, they can lead into side effects like tremors and restless and irregular sleep pattern. So remember these names, diphenhydramine. We have the doxylamine. If you go to the store and check the label, you will see doxylamine with many other names, right? Like Unisom, etc. All right, so let's keep going. So we have the insomnia treatment. So we already talked about the three medications. Barbiturates and benzos are not appropriate for long-term treatments of insomnia. That is number one. Benzos suppress the REM sleep. So listen, the conclusion about this slide is this, that all these medications, if you have hypnotic doses, they're not going to actually make you really be relaxed and wake up with totally feeling that you have a lot of energy. No. Why? Because all these guys are going to decrease the number and decrease the duration of REM. Decrease the number and duration of REM. They are going to increase other stages, like stage 4, for example, stage 3, they are going to increase that, but that doesn't mean that the REM is going to increase. So that is a problem. So no medications can be, no medications are going to make equal the normal sleep of a patient. All right, so let's keep going. We have the barbiturates. All right, so one thing I want to just mention before pass is that we have the residual daytime sedation. Residual daytime sedation, this is in comparison to the benzodiazepines. You already know, benzo very fast and short. The barbiturates is going to last longer and more side effects. Residual daytime, so that means that the effect is going to last longer. So the residual daytime sedation. Headache, blurred vision, and impair of coordination. So what is your nursing consideration here? Is the driving or some machinery that can start using, right? So they cannot use that if they're taking these barbiturates. All right, so we have here barbiturates. If we have taken barbiturates for a long period of time, a rapid withdrawal can lead into anxiety, delirium, weakness, and grand mal seizures. Situation. So what we have here is, if you see this, read carefully this, anxiety, delirium, weakness, and grand mal. If you withdraw this, if you withdraw barbiturates are, so what is the difference between the withdrawal benzos and barbiturates? Probably you're thinking about that. So barbiturates is more remarkable. The benzos do not have, they can have this, but it's not that common. But barbiturate, yes, is going to mostly happen. So this looks like a withdrawal, alcohol withdrawal, right? The patient starts in anxiety, delirium means hallucinations, delusions. The patient starts to feel weak, nauseous, and vomiting. Grand mal seizures, like a situation that is going to start having seizures. So with alcohol withdrawal at the end can lead into seizures. Delirium, hallucinations, something that is working on my skin, etc. Right? Okay, so that is something important we need to remember about barbiturates. Okay, so they can produce hangover, of course, because they are being used for, they can last for 1 or 2 or 3 days, even according to the dose. A rebound phenomenon occurs when the drug stops, but not during the therapy. So, so what we have here is that if you are prescribed the medication properly, you will not be able, you're not going to have rebound effect. Only if you stop the medication suddenly, that can lead into these signs and symptoms, rapid withdrawal. Okay. All right. So let's keep going. Okay. Something is not here. All right. Okay. So we going to continue the benzodiazepines. So remember we was having sand. We talk about serotonin, acetylcholine, norepinephrine, and dopamine. So those are the neurotransmitters that make you sleep, but we are talking about GABA. So that's why benzodiazepines are not primarily used for sleep disorders. So GABA is going to be an inhibitor that is going to produce the sedation of the patient. So for long-term insomnia is not a choice. And these please do not have antipsychotic activity. So it's not used for example, schizophrenia. It's not used for that. It's not used for depression. So they are going to actually not used for those situations. All right, so uses of benzodiazepines, because of they have very fast and short acting, they are going to be used for, can be PO, can be intramuscular. Believe it or not, PO have more absorption than intramuscular. And what happened is that they have short duration and they are being used for patients who need to have some procedures. Bronchoscopy, endoscopy, colonoscopy, we need to have some patients need to be still awake in order to receive some orders. Now, one of the things that is very high yield in NCLEX is that the patients are going to have benzodiazepines are very hepatotoxic, can produce hepatotoxicity. If you have problems with hepatitis or some problems of the kidney of the liver, you need to prevent to use these benzodiazepines. How do you know that? So nauseous, vomiting, jaundice. Jaundice can be an effect already. So what is your nursing consideration? The LFTs, the liver function test. Another thing about benzodiazepines, very high yield, is smokers. Smokers, they may require larger doses because that is going to accelerate the metabolism of the benzodiazepines. We have medications before bed, of course. You're not going to do before you go to work or before you're driving. So that's why we have safety precautions. Dependency, habitual use of benzodiazepines, if you use it for 2 to 4 weeks, that is going to make you be dependent of this medication. So you need to make a tapering. Tapering, how long is going to last? About the same same length, or 2 to 4 weeks. 2 to 4 weeks. Flumazenil, another high yield for NCLEX, is the antidote for the excess of benzodiazepines. All right, so here we have the duration of some of those medications. If you see here, onset is about 15 minutes, 30 minutes, 30 to 60 minutes. They can use about long, depends on the dose. They can last 24 hours, 20 to 22 hours. Short duration is midazolam. This is what we use for procedures, small procedures like bronchoscopy, colonoscopy, etc. That is going to be short duration. That's going to last about 3-4 hours. Flurazepam is a long acting. Just to remark here, we have the lorazepam, the Ativan is very common. That can lead into retrograde amnesia. And we don't take it with food because the absorption is going to be diminished. Lorazepam. Okay. All right, so let's keep going. So we have the no barbiturates and no benzodiazepines. So we have, they're going to have variable effect on the REM, but always any medication are going to decrease the number and the length of the REMs. Solpidem, that is mostly used for hypnotic. So hypnotic. So the benzodiazepines are going to be sedative. Mostly, the most common use are going to be sedative. The barbiturates are going to be used for, they can be for sedation and hypnosis. And these no barbiturates can be used for sedative and hypnotic, but mostly we use as hypnotic medication. Is the Ambien. Ambien. So please remember Ambien. We have Lunesta, and we have, this is the most common actually. Lunesta is the most common name instead of generic, but anyhow they put you the generic too, if they ask you about that. Solpidem, Ambien. So this is must you need to remember. Okay, so another medication we have the Rameltion. The Rameltion is a melatonin receptor agonist. So it's not melatonin. So it's a substance that is similar to melatonin, who is going to activate the receptors of melatonin. 30 minutes before bed, and what is the side effect of this? Is the hepatotoxicity, liver, so contraindicated in liver disease. All right, so another high yield for NCLEX and HESI. We have St. John's wort, GABA, chamomile, passion flower. They actually can produce summation of effect of the sedative. Could be barbiturates, could be benzos, or could be no benzobarbital. Okay, so let's talk about epilepsy. Epilepsy is, we have a chaotic release of neurotransmitters that happens simultaneously. So it's totally a shortcut in the brain. And we have here that these patients, we have about 3 million of these people well, these in the community who are having, or in the population, they have epilepsy. All right, so let's keep going. Risk for epilepsy. So those are babies who born with intrauterine growth restriction. It could be from mothers who are alcoholic, from mothers who are addictive to psychedelic drugs, smokers, too much coffee, etc. And they, for example, we have neonatal seizures. So at the time that the baby is born, if they have some kind of level of ischemia, they can lead into seizures. So any seizure, it could be temperature too. They can lead, any seizures in very early age, they can predispose the risk to have seizures or epilepsy later on. Any problem with the brain? As early the brain is having some injury or problem, that can lead in higher risk of epilepsy. Okay, so that is about, so fever, sorry. Fever is another thing that we always need to be careful. So we don't want the baby to have fever because they can lead into seizures. And the seizures probably stop when the temperature is going down, but your risk for seizures later on never will disappear. So you always need to think about it. Okay, so we have other problems, the brain problems or stroke, sodium, calcium. Sodium, calcium is the entry of sodium and calcium for the depolarization of the nerves. So any problem of hypo or hypernatremia, hypocalcemia, they can lead in problems of neurological problems that can lead into seizures. So as a conclusion, and a very high yield, is when the patient is coming with seizures, unless the patient is being already diagnosed already with bracelet that you need to recommend to use, if that is the case, that is being diagnosed of epilepsy, you don't know why is the patient having seizures. So for that, they need to investigate all what we have: infections, injury, hypoglycemia, very important, hypoglycemia, and electrolyte balance, so sodium and calcium, okay? Pathophysiology, just two words here: excessive excitation or loss of inhibition. So we have inhibitor hormones like GABA that are inhibitors that is going to control the movement, but this GABA is supposed to be high, but it's low. So it's less inhibition. We have excessive excitation. We have the noradrenaline, adrenaline. We have the glutamate, that is one of the main excitatory neurotransmitters, are in this case high. So high excitatory, low inhibitory neurotransmitters. Okay, so we have here seizure classification: primary or idiopathic. Means we don't know the cause. Secondary, all the reasons that we saw before. By type of seizure, we have partial or focal, and we have the generalized convulsive disorders or convulsive seizures. With the black box here, warning is that they can, regarding to the risk of suicidal thoughts, so they have suicidal thoughts as the time they are taking this medication. All right, so here we have the first classification. Remember, please, this: partial or generalized. Okay, partial or generalized. Partial is divided in simple and complex. Simple and complex. Simple and complex. Simple and complex. So what we have here in the partial, so let's go back here. We have the partial. These guys are going to mostly be conscious, which is going to be awake. Or in the we have the simple is always awake. The complex can be awake, can be loss or no loss of consciousness. Okay, complex. So we already talked about the different. I cannot show you how is the seizure, so you can actually just remember that these we are mostly considered without losing a consciousness. So that is called partial. It can be partial, could be, for example, the movement of your one arm. So you cannot control. Your arm is hitting the table, and you're looking your hand hitting the table, and you cannot stop. So that is going to be a simple partial seizure. A complex is going to be involve some of kind of alteration of the consciousness. It could be totally awake or loss of consciousness for about 15 to 20 seconds. And there's going to be erratical movements that without any sense. There is no purposeless movements of your arm and, for example, smacking your mouth. So that is complex. So partial. So we have medication for partial, and the other group we already talked about partial. Let's go to the generalized, and the before that we have different medications that I'm going to show you how to memorize this at the end. So this is very important. And generalized, we have another medications that are going to be given for seizures or convulsions. One last thing I want to tell you. Partial is going to be one hemisphere. Generalized, general, all over, right? So it's going to involve two hemispheres. So we have here the absence, petit mal. Conclusion here, absence is all these guys are going to lose consciousness. The most important are going to be these two. We can discuss another time these three ones. But absence is when you are totally looking to the space and there is no you don't move you're blinking your eyes probably, but you're not actually looking at. It's just like looking in the immensity of the universe. So petit mal, and these petit mal do not have aura. Aura, mostly aura coming in the tonic, clonic, or grand mal. That is the classical that we actually thinking about convulsions or epilepsy. So we talk about the tonic, clonic. Tonic because you start to have some rigidity of the muscles. When you have this rigidity of the muscles, you then start to have these extensions and flexions. So it's tonic, rigidity, and after that you have the clonic, the extension and flexion of the extremity, grand mal. And this guy is going to have what we call the aura. What is the aura? The aura is something that even smells. You see something smell very, very bad. Something feels something wrong. So your eyes start to see like a smoke around. So that is the moment where after few minutes, couple minutes, you start to having the seizures. Okay, so let's focus on these two, generalized absence and tonic-clonic. So here we have absence, petit mal, no aura, generalized, loss of consciousness. What we need to remember is the succinimide. So this is typically for absence of seizures of absence seizures. So it's the succinimide or petit mal. We have the other, the tonic-clonic, that is the classical, let's put it this way, is have aura, is going to last 1 to 5 minutes. The aura is going to be about a few minutes, 2-3 minutes, and then the seizure is going to last about 1 to 3 minutes. I saw 2 minutes, but 5 minutes a little bit longer, but it's about 1 to 2 or 3 minutes. Post-ictal, always question for NCLEX. Post-ictal is a situation where the patient is after the seizure. After the seizure, you say, okay, I finish with the seizure, I start to do something different. No, actually the patient ends totally extenuated. They want to sleep. They are confused. And one nursing consideration that always asking in NCLEX and HESI is never leave your patient. Never leave your patient during the seizures and after the seizure. How long is going to last the post-ictal? Post-ictal is going to last about 20 to half an hour. 20 to half an hour. What happens if the patient want to stand up? So it's going to be risk for injuries, right? Okay, so here we have the we have hydantoin, phenytoin, toin. All these toins are going to be the family of the dilantin. That is the most common. Dilantin, then we have phenobarbital. When it's not enough, the effect, they add phenobarbital. Valproic acid, that for a long time was the first line of of treatment for gang mal now is the phenytoin, carbamazepine, topiramate, and primidone. Carbamazepine, these three guys, they can be used in addition to the previous one, but they can have another uses too. Like, for example, kernel nerve number 5, this trigeminal neuralgia, very bad, or migraines are going to be used, these medications. All right, so we are going to have a clear idea which medications we are going to use in the next slides. Okay, so can you see here we have partial, and this is both together. This is the generalized, right? So generalized can be absent, can be tonic, can be other ones that we didn't mention, or we just saw it in the previous slide. But absence, succinimide. So this guy is very common to us for NCLEX. Here we have the tonic clonic. We have the phenobarbital. Phenobarbital is being used after these guys are not so effective, and they're going to add the phenobarbital. So here we have the hydantoins, that is the group of hydantoins. We have phosphenytoin and phenytoin. So before they was using very much the dilantin, is the phenytoin, but then it was coming into the market, the phosphenytoin, that is having less side effects as this guy. So that's why the first line now is going to be the phosphenytoin. All right, so here we have a lot of names, right? So look at this. I want you to remember the main names, you to be familiar with the main names. Hydantoin, so everything that ends in toin. Okay? We have phenobarbital. Those are the barbiturates, right? We have the valproic acid, carbamazepines, topamax in the top, primidona, or primadonna. Primadonna is a singer in opera that are having the main role of singing. So that is the primadonna. So just remember, primadonna is on the top. That is actually for generalized. If you can see, these two guys are not repeated in the rest. So that is a way to get familiar with this name. So I will continue. If there are some questions, please just raise your hand. I will see about 5-10 minutes more. I'm going to check hands. If you raise your hand. Status epilepticus, simple. Patient having epilepsy, and there is no stop. They are going to, the seizures last 2-3 minutes, stop, and then start again. And then start again. So stop, and then start again. So that is status epilepticus, and that is going to last in about half an hour. So that can lead into the patient's death, because besides that, they are going to produce a lot of salivation, seizures, problems with hitting his head, right? This patient, in between the seizures, they are not even recovering consciousness. So look like he's sleeping and start to seizure again. He never is going to wake up. Okay, during half an hour, and that can produce ischemia, cerebral ischemia, and can produce coma and death of the patient. So your precautions as a nurse, you need to do the ABC. Turn to the side of the patient, right or left, depends if you are right or you're right or left-handed, whatever is easy, and very in a surface that is hard, for the floor, for example, is going to be hard floor, is in order to put a pad here on the neck, just to prevent him to hit himself against the floor. And never put your hands inside the mouth of the patient. Never. Okay, hyperextend the head in order to prevent the patient can get asphyxiated with the tongue. All right, so ER seizures, we have diazepam, anti-epileptic drugs. So what they are going to use, number one, is the phenytoin. Toin is a family of the Hydantoins, right? So we give about diazepam, 10 milligrams intramuscular, and that is going to make stop the seizures. If that is not enough, we add phenobarbital. In order to keep controlling the seizures as a maintenance, you're going to use phosphophenytoin, so Hydantoins. For emergency situations, you're going to use diazepam, or they are going, especially diazepam and phenobarbital. For maintenance, you're going to start giving anti-epileptic medication. Well, one important thing that I just was reading in one of the exams that test exams that they have in different books, we have that there's children that have refractory seizures, and what they are going to give to these children is a ketogenic diet. Ketogenic diet. What is a ketogenic diet? Produce ketone bodies, right? So looks like the increased acidity of the blood is going to decrease the recurrency of seizures, especially in children. Ketogenic diet, if you remember, ketone bodies is produced by fat. So that means that the diet is going to be low in proteins and low in carbs, but high in fat. Okay, so that is one of the measurements that are going to be in cases of children with refractory seizure. What is refractory seizures? That means that is seizure after seizure, seizure after seizure, right? Not in the same day, of course, but they are going to have very often presentation of seizures. All right, so here we have, we're going to stop a little bit here because this is super high yield for NCLEX. And we have all the names, Toin again, okay? So what we need to remember is that they're being used for side effects. Before that, you need to dilute in 0.9% normal saline solution. And don't mix it with other medications. Don't mix it because they are going to precipitate. So just dilute in 0.9%, and the injection should be about 25 micrograms for every minute. So that is actually a slow infusion. Just remember, a slow infusion. Side effects, and that is where is the party start here with the Hydantoins, is number one, gingival hyperplasia. Gingival hyperplasia. What is gingival hyperplasia? Is increase of the size of the gums, right? Or gum hypertrophy is the same. Now, the patient said, okay, if I have gingival hyperplasia, can I stop? I'm going to stop my medication. I don't want that. So that is totally wrong. You need to continue the medication. So what you're going to do just is oral care. Another one, we have hyperglycemia, very important. Hyperplasia, hyperglycemia. So what is the hyperglycemia? High levels of glucose, of course. What is your nursing consideration is patients who are diabetic patients. Diabetic patients, they are going to probably increase the dose of the oral anti-diabetic medication, okay, or the insulin. Blood dyscrasias and hepatotoxicity. Blood dyscrasias are going to be any alteration, could be low levels of white cells. One thing is that another characteristic of Hydantoin toxicity is the nystagmus. Don't forget that, nystagmus. Nystagmus is one of the high yield questions. Nystagmus, it can lead, can tell you that probably you have toxicity levels of Hydantoins. So if you see on the right corner upper here, we have the therapeutic dose, 10 to 20 micrograms per liter. And this is very important. Why? Because the therapeutic range versus the toxic level are very close, are very, very close. So it's in the level of micrograms, 10 to 20, okay? All right, so hypertrophy of gums is the same to say, as we said, gingival hyperplasia, right? Another thing you need to remember is a pink or reddish brown urine. The urine decoloration is going to be pink or reddish brown, so pink. So another high yield for NCLEX. All right, so we have the list of medication. We have the carbamazepine. That is going to make effect in a few days. No, it's not immediately. They can produce nephrotoxicity. Carbamazepine is one of the medications for seizures, right? And is going to produce problems. So contraindication, hepatitis. So if you have hepatotoxicity and the patient is having problems with the liver, is contraindicated. Okay, so another here is that if the patient is Asiatic or from Asia, carbamazepine has some specific side effect for this group of the population. Chinese population or Asian population, they have a problems of necrosis of the skin. It's a Steven-Johnson syndrome, and is actually produced mostly in Asian population. So be careful with people who are coming, who have this background. Phenobarbital is going to be long-acting. We have succinimide. So we already talked that this is the one I want you to remember as is the only one that is the, so succinimide, don't be confused with the tuxus, is all the same, okay? And they are going to produce nausea and vomiting at indigestion, especially at the beginning of the treatment. At the beginning of the, so that is going to just go away in few days. But succinimide is the only medication, so you can remember, we can remember that, are going to have this nausea, vomiting, indigestion at the beginning of the medication, then disappear. Okay, so these actually are some medication for status epilepticus. Valproic acid is the grandpapa, grandmama of all the medication. Valproic acid, hepatotoxicity. So you can tell something in common with all these anti-seizures, right? Hepatotoxicity. Hepatotoxicity can be actually the one of common side effect of all the anti-seizure medication. We have the Lamictal. Lamictal, very common. It's for partial seizures. Gastric irritation, and take the met with fluid and food. The lamotrigine or Lamictal. Okay, so that is what we was talking about seizures. So let's keep going. We have the last few ones and before we are going to get familiar with the medication, and that's what I want you to be familiar with, is we have the Topamax on the top. Okay, the top is actually used for generalized seizures. They can be used for migraine, Gabapentin, partial seizures, can be used Neurontin, neuropathic pain. Keppra, that is for partial too. That is going to be weakness, drowsiness. Please just remember this. Be familiar with these names. Keppra, mostly they are going to give you Keppra or levetiracetam. Oxcarbazepine is the Trileptal, is partial seizures. Pregabalin, partial seizures. So I just mentioning, but definitely I trying to just mention because we are going to have a slide specifically to remember these names. Partial seizures. So if you have partial seizures or any seizures and you feel better, okay, I stop the medication. That is totally wrong. You need to take it forever, right? For if you are diagnosed for epilepsy, you cannot be cured. So you have always a risk if you don't take a medication to have a seizure. Gabatril, the Gabitril is partial seizures. We have the Sonogram, partial seizures, skin rash, nephrotoxicity, and blood discussion. Okay, so in conclusion, what do you have for all these anti-seizures? We have hepatotoxicity, nephrotoxicity. They are not going to ask you specifically, they are not going to be that specific to say what is the difference between this medication and another medication of anti-seizures. No. If they ask you something about hepatotoxicity, most likely that could be the answer. or nephrotoxicity. Again, most commonly is going to be the hepatotoxicity. Now, second are going to be the blood dyscrasias. Can be elevation, or sorry, the diminution of the red blood cells, platelets, so you can bleed. So that could be a cause by anti-epileptic medication, right? So you have bruises, something, blood dyscrasias. So this is a kind of common situation for patients who have epilepsy treatment. And nephrotoxicity. Another thing that you need to remember is that they can lead into skin problems. Rash, right? Rash. This is very important, rash. Topamax, again, for generalized. Primidone is the prima donna, blood dyscrasias. So you don't need to really remember prima donna blood dyscrasia, because the questions are going to come in a way that mostly is the only option is going to be blood dyscrasia. If they put the Primidone, if they put you, for example, Topamax, Socinamide, or they are going to put you another medication you already know that most likely could be hepatotoxic, blood dyscrasias, nephrotoxic, and skin rash. All right, so nursing diagnosis, we have risk for thermal suffocation, risk for ineffective airway clearance, so you already know your interventions and with these patients. The goal is not to cure, it's just to minimize and to reduce the frequency of seizure activities. All right, so never leave the patient alone. So the patient need to be always with you during and after the seizure. Patient education, health promotion. So everything that could be giving a stress to the patient can release in convulsions. Another thing I want to mention is strong stimulations, like, for example, strong light directly to the eyes. That can lead into seizures. Spices, alcohol, everything in extreme, they are going to lead probably into seizures. Okay, so what is the purpose of all these medications? Is to increase the threshold for seizures. To increase the threshold for seizures. If you don't take your medication, your threshold is going to be very thin. So any changes in your life can lead, trigger out a seizure. So that is a treatment for life. All right, so here we have hepato, nephro, and dyscrasia. See what is the most crowded here? Dyscrasia, right? So we have all the medications here. Hepatotoxicity, nephro. So number one is going to be hepato and dyscrasias. Dyscrasia, what is dyscrasia? Any abnormality of the blood. Low levels of platelets, low levels of white cells, low levels of red blood cells, any alteration. Could be 1, 2, or combination of 3. And nephrotoxicity. Okay, so here we have, please, I want just to, we are going to just very soon finish, but I want just you to see this. Hydantoins, toin, right? Toin. You already know that this high, super, ultra, hyper yield for NCLEX, the Hydantoin. Phenobarbital, valproic acid, is carbamazepine, it's not ARBA, it's carbamazepine, Tegretol, Topamax, and Primidone. So prima donna on the top, prima donna, top, prima donna, carbamazepine, and it's easy to remember. Hydantoin, phenobarbital, Hydantoin, phenobarbital. You need to remember valproic acid, that is the grandmama of all, the first medication for seizures. Carbamazepine, that is very common for migraine, but is used for what? For seizures. All right, so the rest, look at these names. Sonizamide, tigabalin, pregabalin, oxcarbazepine, Gabapentin, lamotrigine, levetiracetam. All these guys, just keep a look that if you remember this and you remember this, the rest is going to be for partial. So here, that's what I put it here. We have this circle is for, this is for generalize. Here is the partial, only the partial, and here is what is in common. So if you remember this, you will remember many of the things. So we have here, for example, Topamax, Primidone. Primidona on the top, generalized. That is specific for generalized. We have focal and generalized together. We have the Hydantoins, so toins, phenobarbital, Valproic, and carbamazepine. Carbamazepine, Valproic, phenobarbital, Phenytoin, etc. So they can be used for partial and for generalized. These are the ones for generalized. This is for focal and generalized, and the rest is going to be partial. All right, so that is something that you can actually read with a little more patience. Spasms, let's talk about the third topic, spasms or contraction of the muscles. It can be for many reasons. It could be for accident, for you twist your back, or some hyperextended or stretch out of the muscles. It can produce spasms. So you stretch out, the muscle start to contract, and that so overstretching can lead into spasms after that. All right. So let's keep going. So okay, so this is already high yield so much. So please, malignant hyperthermia and neuroleptic malignancy. What is neuroleptic? Is anti-seizures, right? For seizures. So we have, sorry, antipsychotic. So we have here the dantrolene. Dantrolene is used muscle relaxant. Malignant hyperthermia and neuroleptic malignancy are going to be similar. The difference is the malignant hyperthermia is caused by anesthetics, and neuroleptic malignant syndrome is caused by antipsychotics. So neuroleptics are antipsychotics. Okay, so they have high fever, high temperature. The malignant here have high fever, but not as much as this. But the common thing for both of them are the contracture or the muscle are going to be totally having spasms. So what is the problem with this? The problem is the diaphragm and the intercostal muscles. If you have that spasm in that areas, you can have respiratory arrest. So for both malignant hyperthermia and neuroleptic malignancy syndrome. All right, so we have spasticity. What is spasticity? Spasticity means a state of contraction. Period. That's all. So who produces spasticity? So we are going to have, for example, the multiple sclerosis and the MS. MS. Some keywords here. Autoimmune. They have no myelin. So the myelin of the axons are disappearing. And just remember this. Multiple sclerosis. Multiple is going to be myelin. So that's how you can remember. And the treatment for that high yield is the Baclofen. Baclofen. So here you can read here the ALS is not that common, so I'm not going to go on that. But multiple sclerosis, yes, is very high yield. All right. So Baclofen is going to be used for spasms and multiple sclerosis. Risk for injury related to decreased sensorium. So the sensitivity of things are going to decrease. And that is Baclofen. This is the cyclobenzaprine. Cyclobenzaprine. Cyclobenzaprine is the most common muscle relaxant using for spasms following from muscular injuries. So cyclobenzaprine. Okay. Okay, so we have the neuromuscular blocking agents. So neuromuscular blocking agents, the neuromuscular junction, right? Neuromuscular junction. Okay, so here we have, forget about no depolarizing. Depolarizing is just to make a classification, but the one that is going to be acting in the NMJ is going to be the succinylcholine. NMJ is the neuromuscular junction. It's the succinylcholine. It's the shortest duration. It's very useful. Why? Because they're being used for surgery. So you don't want, the surgeon, we don't want to have a patient who is stiff, totally stiff. You cannot even move. You cannot distend the muscles or the organs inside because the muscles, the patient is totally contracted. So we need to relax the patient. And the anesthesiology is the one that say, we want more, I want more relaxed this patient. So what they're going to do, succinylcholine, and the anesthesiologist is going to look very upset because the more succinylcholine can be more difficult to return the tonicity of the muscle again. So anyhow, so succinylcholine. Okay, so let's do. I think we finished the webinar today. So I'm going to open microphones. Let me see if I can finish. Okay. Okay, I don't know if you can hear me. David, thank you so much. Margarita, thank you so much. Jasmine, thank you for coming. So I can, okay, so I cannot hear you, I cannot open microphones, but thank you so much for coming. If you have any question, please raise your hand. I will be more happy to answer. If there is no questions about it, so please just say, oh, Jasmine, I can hear, your microphone is open. Any question?
No, thank you, Dr. G.
Okay, thank you too for coming. David, thank you so much too.
Yeah.
Margarita, can you open your microphone? Okay, if you cannot, that's fine. So, all right. Okay, guys, thank you so much. Oh, Margarita, gracias. Thank you so much.
Yeah. Have a good night, Dr. G.
I will see you next time. Thank you so much, everybody.
No, Dr. G.